beta blocker, but the AV node is also affected, that AV node is going to drop the heart rate. That AV nodal ischemia or infarction is going to drop the heart rate. On top of that, we give them a beta blocker. You're going to further drop the heart rate. You're going to precipitate a complete heart block and possibly cardiac arrest. Okay, so very cautious, if at all. You withhold beta blockers many times for inferior MI until we stabilize the patient, put them on the beta blocker afterwards. But acutely, safer thing is to withhold the beta blocker to prevent the arrhythmia. All right. We could have reinfarction and cardiac failure. As I said, cardiac failure takes very short to teach, and I'll correlate everything I did before to heart failure. Within days 3 to 7, complications of MI include the rupture of the heart. There are 3 things that can rupture: the free wall, the septum, and the papillary muscles. The papillary muscle rupture is most likely to occur with the mitral valves. If your papillary muscles rupture the mitral valve, you will have a mitral regurgitation murmur. It's going to be a new onset murmur post-MI. So anytime a patient has a new onset murmur post-MI, it is going to be one of 2 things. It is going to be due to either septal rupture or a papillary muscle rupture. If the murmur is at the apex, a pansystolic murmur at the apex radiating to the axilla, that suggests papillary muscle rupture and mitral regurgitation. However, if the murmur is at the left lower sternal edge, then that patient probably had a ventricular septal rupture. And therefore, they will have the murmur of a ventricular septal defect. That is a pansystolic murmur at the left lower sternal edge. And so the likely condition there is likely cause a septal rupture with a new onset ventricular septal defect. Okay, so in your MCQ, you're looking for where the murmur is. If it's at the apex, we just did murmurs, right? So if it's a mitral regurg murmur, then it's mitral regurg. However, if it's a VSD murmur, then it's septal rupture. All right, so we'll answer that question because I think we had mixed answers there. And of course, the third thing that can happen is free wall rupture. And so if a patient, pay attention here, if the patient succumbs to sudden cardiac arrest within 12 hours or within 48 hours, the most likely cause of that cardiac arrest is ventricular fibrillation. However, if that patient presents with cardiac arrest 3 to 7 days after, with no exam findings, no real ECG changes, it's just a sudden cardiac arrest, 3 to 7 days after, that patient probably had free wall rupture, and that patient went into cardiac tamponade and cardiac arrest as a result. Okay? Are we clear thus far? Reason I'm saying this is because I've seen questions on complications of MI, very, very tricky, and they trick students. We clear on those? Okay, fantastic. Right? And so for cardiac tamponade, what are your ECG changes for cardiac tamponade, guys? ECG changes, cardiac tamponade. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. So pericardial effusion and cardiac tamponade present with a low QRS amplitude. And very good, Brianna, electrical alternance. Okay, so those electrical alternance is varying QRS amplitudes, okay, with each heartbeat. So each heartbeat has a different QRS amplitude, but generally it's a low voltage or low QRS complex, right? So that's cardiac tamponade or pericardial effusion. Electrical alternance is more specific to cardiac tamponade rather than just a simple pericardial effusion, okay? And then within weeks to months, well, we know about Dressler syndrome. Dressler syndrome is where they have recurrent pericarditis within weeks to months after the MI. And we just treat that with high dose aspirin and NSAIDs, right? It's inflammation post MI. They'll have an elevated ESR and so on. Okay? So pericarditis can be a complication of myocardial infarction. If it's acute, it's called fibrinous pericarditis. If it's chronic, then that's just Dressler syndrome. Okay, and that is coronary artery disease. I placed this picture here to remind you all there are different types of myocardial infarction. I have a homework question on this, and you will give me your answers. I want to make sure you're all studying as well. And this is just a little, you all don't need to know the TIMISO and so on, right? The only real score you all need to know is cardiovascular. Okay? So I know that that was a lot. I know I always go beyond time, no matter how much. My God, I always go beyond time. But the last topic we have is heart failure, and I do heart failure and promise you like 10 to 15. Yeah. Hey, can you hear me again there, Sarah? Okay, cool. Right. So that's coronary artery disease, ischemic heart disease. That was a lot. I know it was a lot. Are there any questions on any of the aspects of ischemic heart disease or anything that we did? We went through a couple very high yield by the ways when rhabdomyolysis and multiple system atrophy and stuff as well, right? But we know how to manage stable angina. We know to work up with stress tests. We know to do coronary angiogram. We know the difference between exercise and chemical stress tests. We know the difference between STEMI and STEMI on stable angina and stable angina. We know the ECG leads and their relevant um, representation in terms of the affected area and the occluded artery. We know the management of STEMI and STEMI. We know all the complications of MI, how they present, and we know a lot more than that as well. So we're clear on that, guys. Now we're going to answer questions, take a 5-minute break. Yeah, hi.
What did you say that the ACE inhibitors was specifically doing?
They prevent cardiac remodeling. That's the importance of them. I can't go further than that. I just know that that's a academic teaching, right? I don't know how, but they prevent cardiac remodeling. That's an important point.
Thank you.
You're welcome. Thanks, Julian, for that question. Any more questions, guys, before we move on?
Hi, I just wanted to ask a
Hi,
question.
Tira. Sure, what's up?
Okay, just to reconfirm. So you said that if the baseline ECG is abnormal, then after the
Yeah,
stress test, you would do an echo and the MPI over the ECG, right?
yeah, that would make more
O-
sense. Yeah, that's preferred. Yeah, academically, yeah, sure.
Okay, so all right. So if the baseline ECG is normal, then we would just don't do any further testing with the echo or the MPI.
Right. So as I said, it depends on where you're doing it, right? In a real life scenario. So what we want to do, the concept of stress testing, is to see if they have ischemic changes when the demand or supply is off, when there's a demand supply or incongruity, right? So when we do a stress test, we were looking for ischemic changes. So depending on where you are, an ECG might suffice because you could see ischemic changes after you induce the stress. Depending on where you are, you might not have MPI, so you might do a ECG and echo only. Depending on where you are, you might have all three available, so you do ECG, echo, and MPI. But once you have these ischemic changes on ECG, that usually suffices for a stress test. But most times when we're doing patients, working up them for stress testing, we'll do an echocardiogram one time as well. Yeah,
Okay, thank you.
you're welcome. Any more questions? Thanks for the question, Tahira.
I got a little lost on the
Shita.
complications of MI for the rupture of
Mm-hmm.
the heart.
Yeah,
We're seeing that the septal, if it's a septal MI, would cause more of a VSD. That's what you're saying.
yeah,
And for
yeah.
mitral, it would be apex. And I didn't hear what the other one was.
Sure. So there's your heart, right? This is um, right atrium, left atrium, right ventricle, left ventricle, right? We're gonna put here just for simplicity's sake. So this is left atrium, right atrium. This is right ventricle. This is left ventricle. So for simplicity's sake, we're just gonna call this valve here the mitral valve. We're gonna put in here in what's a good color in blue. We're gonna put in here our ventricular septum. right? And here we're gonna have, this is the pericardium, right? So this is the pericardium, okay? So within 3 to 7 days, the complications could be that here, the muscles here, these are your papillary muscles, you have ruptured papillary muscles, all right? So if you have ruptured papillary muscles at your mitral valve, what you're gonna have is blood flowing back up, and a papillary muscle rupture would result in mitral regurgitation, right? So the mitral regurgitation murmur we know is pansystolic at the apex, radiating to the axilla. So the first thing that could happen is papillary muscle rupture at the mitral valve, and you have mitral regurgitation. So that's one complication. The next thing that could happen is the ventricle can rupture. If the ventricle ruptures, right, you're gonna have a ventricular rupture. Sorry, septal rupture, my bad. Septal rupture. Guys, hear me? I'm not willing to use this thing, right? So, septal rupture. This is our right ventricle. Right, this is our left ventricle. And our septum is now ruptured, right? So the septum is a rupture. So it's ruptured, it's open. Okay, can you answer? Right, you'll hear me again there? Adil? Hear again? Yeah. Good, thanks. Right, so I was saying that you could have a ventricular septal defect as a result. So complication one, we said, was mitral regurgitation caused papillary muscle rupture. Our septum could rupture, and once our septum ruptures, we have no more septum, and therefore the blood will go from a high pressure point to a low pressure point. So what you have is shunting, just like you have in a congenital heart disease. So with ventricular free wall rupture, you have the same thing as a ventricular septal defect. And this could also precipitate a right-sided heart failure, because when the ventricle septum ruptures, the high pressure in the left ventricle will push blood to the right ventricle, which will then back up to the right atrium, back up, and you have right heart failure, or right heart, increased pressure in the right side of the heart, right? So you have a ventricular septal defect because of ventricular septal rupture, and that presents as a pansystolic murmur at the left lower sternal border, right? Just like it does for ventricular septal defect in peds. It's exactly the same thing. Same thing for mitral regurg, it's exactly the same murmur in terms of papillary muscle rupture. And the last thing that can happen is your cardiac muscle can rupture. So if your cardiac muscle ruptures, what's going to happen here? If your cardiac muscle ruptures, all the blood is going to come in this space. All the blood is going to pool here. And so you're going to have a massive pericardial effusion. Pericardial effusion. P is not pulmonary embolism, that's pericardial effusion. And therefore it can precipitate cardiac tamponade. Cool? Does that clarify the complications for you, Shweta?
It does. Thank you.
Okay, great. All right, guys, any more questions? Yeah, I've seen people leaving because I'm teaching for so long. Damn, I just get carried away. I just want to teach all everything and make sure they understand everything. I'm sorry. Heart failure will be quick. Any more questions? Can we go back to answering our questions now? Yeah, no, maybe. Yes, okay, cool. Right. So let's go. right? So I'll just answer this first one. So the ones that you all got correct, I'll just answer it and teach around it one time. Okay, so this patient, most of you all got correct. This is coronary angioplasty with stent A is the correct answer here. Why? This is a 65-year-old male smoker presenting to ED with crushing retrosternal chest pain, shortness of breath, and it began 1 hour prior to his presentation. He has a history of hypertension, COPD, and dyslipidemia. His oxygen saturation reads 85%, ECG shows STEMI NV1 to V4, and you decide he has ACS STEMI. You gain IV access, start aspirin, GTN morphine, oxygen, because his oxygen is low. And which of the following is the best method of managing this patient in the acute setting? That is A, coronary angioplasty with stent. There's only 1 hour of symptom onset, so he did present early. The best method of managing him would be primary PCI, right? CABG, no. Thrombolysis would have been an option if we didn't have PCI available within 2 hours, or if the patient had no contraindications to thrombolysis as well, then we do thrombolysis based on our time, and anticoagulation makes no sense here. So my question is, we all already answered it, left anterior descending artery, because it's V1 to V4, that he has the ST elevations, and so it's an anteroseptal MI. If I told you that this very patient, this exact patient, had ST elevations in leads 2, 3, and AVF, given everything else in the stem, which class of drugs would you proceed with caution or not use at all? Or the better MCQ is, which class of drugs would be least likely to be appropriate? Yes, fantastic. Beta blocker. Okay, all right, well, it's still with me. Fantastic. Love it, great. Good. That's one thing down. Number 5, a 63-year-old woman presents to ED complaining of retrosternal chest pain and shortness of breath. Sorry, I was reading something. Yeah, an ECG is done as MI is suspected without the following disease likely. Well, we did say T-wave inversions, ST depressions, and elevated tropes because it's a myocardial infarction. But our new onset left bundle branch block is more likely to be seen in a STEMI. And NSTEMI can also present with a normal ECG. And that's the importance of looking at the clinical picture, saying, all right, this patient probably has coronary artery disease with this persistent chest pain. So when a patient presents with a persistent chest pain, it's unrelieved by nitroglycerin. They having vomiting, nausea, diaphoresis. I skipped past the presentation of MI because I presume you all know what a heart attack looks like, but it is in the guide when you read it if you're not sure. But left-sided chest pain radiating to the jaw, the left jaw, the left shoulder, with nausea, vomiting, diaphoresis. Some patients may have epigastric pain and vomiting like diabetics. They may just have vomiting only, a silent MI, we might call that. But in any of these patients, we think in MI, it's very important to do your tropes because the ECG could be normal, and that's another teaching point for real life there. Okay, and I want to repeat an ECG also because a normal ECG at the health center can now present as a STEMI when it reaches the AED, and I can tell you I've seen that in real life about 3 times. All right, so it happens. So know your ECG findings, and A is the answer here. It's least likely to be seen in NSTEMI. So now that we went through that nice little drawing to explain the complications of MI 3 to 7 days or 2 to 7 days after, can we answer number 6? I want to see like real answers. Like 5 more. Exceptional. So I see no A's anymore. I presume that this concept is clarified. This is a 63-year-old male admitted to A&E 2 days after discharge, following an apparently uncomplicated MI. He now has rapidly worsening shortness of breath over the previous 48 hours. Right? And he's tachypneic with a regular pulse, however, so it's not AFib, and it's a sinus tachy. So this guy JVP was raised and a pansystolic murmur was noted, maximal at the left sternal edge. That raised JVP was exactly why I did the illustration. Remember, we said with the ventricular septal defect, that left blood goes to the right side. That left-sided blood, you have left to right shunting. And so that high pressure in the left ventricle pushes the blood across the septum into the right ventricle, which will then push up into the right atrium, and therefore you have distended jugular veins because of the right side of the heart. Nice and easy, right? And then he has a ventricular septal defect, so he has a ventricular septal defect murmur, which is pansystolic at the left sternal edge. 100% correct, guys. Excellent, right? That is excellent. Everyone, I presume, was clear on that because I had no questions. I'm gonna do heart failure. So my question to you is, it's 8:53. I said I was finishing half eight. I said I was not doing this. This is the reason I split my class, and I'm still going way beyond. Do you all want to take a break, or do you all want to go straight into heart failure? Because I can go forever. The break is not going to be long either way. Straight. I love this group. All right, I fire. All right, good. All right, guys, nice. So the good thing is for heart failure, they only ask 3 things, all right, in different ways. So this is the first thing. This is the second thing. No, this is not the second thing. I want you all to do 11. I only have 2 questions. All right, good. So answers in the chat to number. Actually, let me do number 11 first. Number 11, right? Answers in the chat to number 11, please. Because this kind of ties up the topic we did before, shouldn't it? It should. Right, also more answers. Okay, I'm now seeing them coming in. Right, so we'll answer it one time because it covers the topics we just went through. Right, fantastic. I said so Tahira gave us the answer as to what it is going on here. This is a 62-year-old male with COPD and bilateral lower limb swelling. On further assessment, the patient is noted to have an elevated JVP, enlarged liver, and shifting dullness. That shifting dullness represents what on abdominal percussion? Ascites, right? So has ascites. Shifting dullness is actually the most specific clinical sign of ascites, more specific than fluid thrills, okay? So remember that for your OSCE. Which of the following is to be heard, is the most likely to be heard? We just went through this. This is right-sided heart failure symptoms. The patient has COPD. He probably has some pulmonary hypertension going on there. That pulmonary hypertension is going to back up now into the right side of the heart and probably cause a little bit of tricuspid regurgitation too, right? And so therefore this patient probably has some tricuspid regurg going on. And so the most likely to be heard on auscultation is C, pansystolic murmur, the left lower sternal edge. And we said it's a right-sided heart valve, TRI for tri, and those RIT is also in right. So tricuspid is right-sided. So it's louder on inspiration. So C is correct. Fantastic. A, pansystolic murmur, the apex, loud on expiration, is which valvular heart disease is A? Mitral regurg, good. B is which valvular heart disease? Mitral stenosis, fantastic. E is which? Okay, well, E is kind of weird, but which is E? AR, aortic regurg. We hardly get tested on that features, but that's fantastic. You'll identify it. And a pericardial rub can be seen in pericarditis. Exceptional work, guys. So the last question of the day, based on the last topic for today, would be this heart failure question, this clear-cut heart failure question, and it is by far the most commonly tested theoretical concept on heart failure in the MBBS exam. Okay, so the only other question I saw that straight from this was the NYHA classification. That came actually for December, but usually if they bring in a question on heart failure, it's on this concept, right? So answers in the chat to number 10, please. I want as many answers as possible, because if you get a question on heart failure, this is most likely to be the theory tests, the concept tests. Okay, exceptional work, right? So guys, we're gonna do heart failure in terms of a little bit about the pathophysiology, and then I'll tell you all what they test on. But just to bring together our understanding of heart failure, we'll try and teach it
This is heart
in
failure, no?
10 minutes. It's 9 o'clock, so we'll try and finish before 1:15. Okay. So good. I do have heart failure on my guide somewhere. Okay, here it is. Okay, great. All right, gonna turn off and put back on. All right, you all hearing me again here? Because you know I switched screens, so this muffled thing. All right, cool, thanks. So we do heart failure. Look how easy heart failure is, right? It's very easy to understand heart failure. So what we're gonna do for heart failure is we're gonna see how we categorize it first, right? So we'll say we have right heart failure, we have left heart failure. Oh, yeah, this one. Just get a little stability in my hand here. Right, so we have right heart failure, we have left heart failure, we have systolic heart failure, and we have diastolic heart failure. And what I want to do is put systolic and diastolic. So I should actually draw this arrow here. So systolic heart failure is also HFrEF, and diastolic heart failure is HFF. Okay, so anytime you see HFrEF, think about systolic heart failure. Anytime you see HFpEF, think about diastolic heart failure. So we'll do it like that first, and then we'll do right heart and left heart in terms, left side in terms of symptomatology. All right, so let's look at systolic heart failure, which is HFrEF. Right? So in systolic heart failure, systole is feeling. Okay, so contraction is feeling. So that means, let's say this is your heart here. Okay, let's do normal heart. So this is right atrium, left atrium. This is right ventricle, left ventricle. That's a normal heart. In systolic heart failure, one of the most common ways it presents is with dilation, okay? Particularly dilated cardiomyopathy. That's one of the most common ways, right? So notice this heart is very dilated. It is very dilated and also very floppy. So it's floppy It's dilated, as in dilated cardiomyopathy. Another reason you could have systolic heart failure is because of a MI, okay, myocardial infarction. So if you have a infarction of the heart muscle tissue, then it could lead to poor contraction. And so because you can't contract in dilated cardiomyopathy and a floppy heart, you can't pump out as much blood. And therefore, the blood pumping out of the heart is known as your ejection fraction. Okay, so you have in systolic heart failure a reduced ejection fraction because systole has failed and dilated cardiomyopathy and MIs are the common causes there, right? It's very easy. Next, we have diastolic heart failure. So in diastolic heart failure, your heart is actually very, what I want to put, fibrotic. I want to put hypertrophied, right? And I want to put sometimes thickened even. Okay, so this is diastolic heart failure. So diastolic heart failure is known as HFpEF. And so ejection fraction is preserved. Why? Because in diastolic heart failure, the problem, diastole has failed. If diastole has failed, that means the filling of the heart is defected. If you have a heart that cannot stretch, it is fibrotic, it is hypertrophied, it is thickened, then you cannot fill the heart. The elasticity of the heart is lost and therefore you cannot relax. It is diastolic heart failure. And so causes of diastolic heart failure could be an MI as well, but the real main causes is hypertension, aortic stenosis is a big cause. And in terms of the right side, anything that causes pulmonary hypertension. So systemic hypertension and aortic stenosis can cause diastolic heart failure of the left side of the heart. Why? In hypertension and aortic stenosis, the heart is contracting against a high afterload. If it's contracting against a high afterload, it has to contract against a high pressure. The muscle becomes hypertrophied and becomes thickened and becomes fibrotic, and therefore the heart is unable to relax as it should. And so you have diastolic heart failure. In diastolic heart failure, your preload is reduced. So if you have reduced preload, that means the overall blood in the heart is less. And so the ejection fraction becomes less. Because the overall ejection fraction is preserved. So let's say we have 100%. Normally, this is 100 mils of blood we can have in the heart. Usually, the heart should push out 60. This is normal. In HFrEF, what happens is we are not able to contract as much blood, so therefore we contract in only 100, right? Only 40, so that's 40% of the blood. In HFpEF, what happens is this number at the bottom becomes less. You have less ability to fill. So if you only fill in with 80 mils of blood, but you contract in 40, you still have a preserved ejection fraction because ejection fraction normal is 50%. So that's the maths behind HFpEF. You have a reduction in your preload and a reduction in how much blood fills the heart initially. Whereas in HFrEF, you have a reduction overall, the heart is able to fill, but it cannot contract your blood, cannot pump out all the blood. Okay? So that's the difference between HFpEF, which is diastolic heart failure, and HFrEF, which is systolic heart failure. All right, good. The last concept about heart failure now is that of right side and left side. So let's say this is, let me start this off a little bit lower here. This is our lung, and this here is going to be our heart. We're going to have same thing. So it's the right atrium, the left atrium, the right ventricle, the left ventricle. Off of your left ventricle comes your aorta, and your aorta pumps blood towards, this is our brain here, and all the all towards the systemic circulation. All right. Coming back to the left atrium would be our pulmonary veins. All right. So this is our pulmonary veins. So this is how we explain the symptomatology. So for heart failure, left-sided heart failure, what is going to happen? The left side of the heart has two things that happens in left-sided heart failure. You have forward failure and you have backward failure. So let's talk about forward failure first. So if your heart can't pump, point about heart failure is you have reduction in cardiac output. If your heart cannot pump, that means you cannot get blood out, and blood carries with it what? Warmth. It carries with it heat. It carries with it color, and of course, it's supposed to see a proper capillary refill. So the symptoms of left-sided heart failure due to forward failure, I have in my document here, would be pool peripheries, pallor, capillary refill being delayed, right? So that's because of your forward failure in left-sided heart failure. Now, let's look at what is more commonly tested or seen is our backward failure. So the left ventricle cannot pump blood. That's the left side, right? So it cannot pump blood out. So all the blood now begins to back up. So it backs up into the left atrium. From the left atrium, where will it go? To the pulmonary vein and enter into the lungs. And so therefore, in left-sided heart failure, big sign is pulmonary edema. And all the symptoms that go with pulmonary edema, I have on the slides. You don't need to write it down. Of course, you can have orthopnea, paroxysmal nocturnal dyspnea, just regular dyspnea or shortness of breath. You can have a cough as well. All right? And then you need to know your chest X-ray findings of pulmonary edema, which we'll talk about. So this left-sided heart failure has forward failure and backward failure. And the symptoms in left-sided heart failure are usually due to cardiogenic pulmonary edema. So what about right-sided heart failure? Well, actually, the most common cause of right-sided heart failure is actually left-sided heart failure. Because what is going to happen there? The blood now backs up into your pulmonary veins, into your lungs. Now it's going to back up into your pulmonary arteries. This is your pulmonary arteries. The pulmonary arteries, blood is going to back up into the right ventricle. That blood in the right ventricle is going to back up into the right atrium. Okay? So therefore, for right-sided heart failure, let's say this is our heart, the right side of our heart here. This is our right atrium and our right ventricle. Here would be our superior vena cava. Here would be our inferior vena cava. So for the right-sided heart failure, the blood now is going to pool up into the right atrium and then go to the superior vena cava. And therefore, common sign is jugular venous distension, elevated jugular venous pressure, right? And remember, your hepatojugular reflux will be positive, right? Your hepatojugular reflux, right? So that's positive. So that's because the blood backs up into the superior vena cava. Then the blood can then back down into the IVC. And when you go from the IVC, this is our IVC, what is going to have here? We're going to have our liver, we're going to have our bowel, and we're going to have here our spleen, right? So if blood backs down through the IVC, what's going to happen? You're going to have hepatic congestion and hepatomegaly. Blood is again going to pool through the portal system and cause ascites, and then blood can also pool and cause splenomegaly via your splanchnic sequestration. Of course, the last thing is the blood could back down to the lower limbs. Oh my God, that's a foot. This is supposed to be a foot, right? And it can lead to pedal edema. So that's how right-sided heart failure presents with jugular venous distension, hepatomegaly, ascites, splenomegaly, and pedal edema. And that's how that happens. So anytime you see a patient or anytime you see a question testing heart failure, you now can know whether it's right side, left side, congestive, wherever. So that's the academic teaching there about heart failure. All right, guys. So I hope everything is clear. I see no questions thus far. The last point to close off this class would be what they actually test about heart failure. Right, so we have the symptoms here, left-sided, we said is due to pulmonary edema. Guys, what are the chest X-ray findings of pulmonary edema? Okay. Chest X-ray findings of heart failure. Sorry, yeah? Not pulmonary edema. Hear me. Heart failure. Yeah. Right. So it's Kerley, Kerley, Kerley B lines. Yeah. Good. Batwing opacifications. Right. Sydney has it there. Right. So it's alveolar edema, cephalization of the vessels, Kerley B lines, and cardiomegaly, and then pleural effusion. Okay. So it's pleural effusion, cardiogenic pulmonary edema, which is represented by some of your Batwing opacifications, Kerley B lines, cardiomegaly, and cephalization of vessels. Right? So this is possible MCQ. So these are your findings on a chest X-ray of heart failure. All right? Good. So to close off this teaching would be, what do they actually test you guys on? They test you all on two things, and that is the universal, the NYHA classification of heart failure. That is class 1, 2, 3, and 4. You all should know this from year 1 to 3, right? Or year 3 at least. So class 1 is no limitation of physical activity. Class 2 is slight limitation, but they're comfortable at rest. Class 3 is marked limitation, but they're still comfortable at rest. And then class 4 is severe limitation, even at rest. Okay, so class 1, 2, 3, and 4, New York Heart Association heart failure classification. This came in December, and it comes, right? So that's the one thing they test. But by far, the most important thing they test for heart failure is that of optimal medical therapy in heart failure. So this is the most important thing about heart failure, and I'm glad that everyone got it correct, right? So these are the drug classes which reduce mortality, that is prolonged survival in heart failure, specifically with reduced ejection fraction. Why have I said it like that? So with heart failure with reduced ejection fraction, the drugs that reduce mortality are ACE and ARBs and ARNIs, beta blockers, MRAs, and SGLT2 inhibitors. So your PRILs, statins, and ARNI, your ARNI, angiotensin receptor neprilysin inhibitor, that is sacubitril valsartan. Your beta blockers are your olols, carvedilol being a big one. Mineralocorticoid receptor antagonists is spironolactone, and SGLT2 inhibitors, empagliflozin and dapagliflozin. These classes of drugs reduce mortality in HFrEF. Thus far, the only worked up class of drug that is actually currently being researched that might potentially reduce mortality in PEF, that is preserved ejection fraction, is SGLT2 inhibitors. This is ongoing research. Okay? The teaching point is these drugs do not reduce mortality in PEF. They reduce hospitalizations, they reduce morbidity, but they do not prolong life in PEF. So please write that down. There's a variety of ways the question comes. Okay? One of the ways the question had come in the past was that they give you the list of drugs and they said, these drugs prolong survival in HFpEF, these drugs prolong survival in HFrEF, they don't prolong survival in HFpEF like that. And the answer was that they do not prolong survival in HFpEF. Okay, so these are the OMT, optical medical therapy drugs that prolong survival, reduce mortality in HFrEF. This is all you need to know. There's a variety of ways. Once you know that these drugs reduce mortality, you know which ones don't. So that means drugs like digoxin, drugs like furosemide, which is a loop diuretic, your thiazide diuretics, your isosorbide dinitrate, morphine, whatever it is, they do not prolong survival or reduce mortality. All they do is reduce symptoms, right? But these drugs, optical medical therapy, they prolong survival. Okay? And that is really all they actually test. This is just a little bit about the acute management of heart failure. I'll probably put them on some diuretics, etc., etc. Okay? But I haven't seen MBBS test anything outside of NYHA or optical medical therapy in one way or the other, because there's a variety of ways they can bring this question. And the same thing I told you all with tricuspid regurg and the right-sided heart failure. Other than that, heart failure comes mainly as OMT. Okay, so once you know that, You probably know heart failure for MBBS, okay? But we went through a little bit of the anatomy and the pathophysiology so we understand it. All right. So any questions on heart failure, guys? That concludes our teaching. We're going to answer a question. I think everyone got it correct. And then we're going to stop class because it's way beyond my time. Good thing is the class on Thursday is much shorter because you're just doing arrhythmias, mainly AFib, and infective endocarditis. Any questions on heart failure? Are we clear? Yeah. Clear on the difference between HFpEF, HFrEF, systolic, diastolic, right-sided symptoms versus left-sided symptoms? I'm seeing Ivana. Hi, Ivana.
Hi, Doc. You could just go over the diastolic HFpEF.
What do you want me to go over there?
So you're explaining the preload, that the preload is reduced. The concept between what is like preserved and reduced.
Right.
Just
So,
that concept there.
so let me say normally, right? In a normal heart, the heart is able to distend. It is elastic. It is able to distend and contract. So in a normal heart, it would probably be able to hold about 100 milliliters of blood. All right. And so in a normal heart, about 60 milliliters of that blood will pump out to give you an ejection fraction. That's the blood being pumped out the heart of 60%. Right. In a patient with diastolic dysfunction, that is patients with things like hypertrophy of the heart muscle, things like restrictive cardiomyopathy, hypertensive heart disease, aortic stenosis, where the heart becomes thickened, hypertrophied, fibrotic, the heart is unable to relax. Okay, so it cannot fill properly. And if the heart cannot fill properly, then the amount of blood being able to fill the heart is less. So the heart now could only actually hold 80 milliliters, but you're pumping out about half of that. So you're still pumping out about half of what it could hold. It's just that you have less to begin with. So your ejection fraction is 50% still, but you're pumping out less than the body requires. So this actually is still reduced cardiac output, right? So you have a reduction in cardiac output, okay? Cardiac output, I think, should be dependent on your preload and your stroke volume as well. Okay, so if you have a reduction in preload, you'll have a reduction in your cardiac output. So your preload is this number here, the 80. It's unable to take as much blood as a normal heart. However, it's still going to pump out the blood, even though it is less blood you're pumping out, to give you a fraction of 50%. Yeah, get that now, Ivana?
Okay, yeah, I understand. Thanks, Doc.
Sure. Right. Whereas just to clarify again, so it kind of brings things together. FREF, the amount of blood is the same, 100 mils, right? You're still able to relax, right? Because the heart is dilated. So it's still filling 100 mils, but it can't pump out anything because the heart is in systolic failure. You have dilation, you have myocardial infarction, the heart can't pump. So systole is not working. So you're only pumping out about 30 mils of that blood. The ejection fraction reduces to about 30%, right? And a reduced ejection fraction is less than percent. Okay? That's clear, right, Ivana?
Yes. Thank you.
Right, no problem. Hey guys, any more questions in heart failure? Right side, left side, diastolic, systolic, Varney's, East, ARBs. Okay, so I have one question for you before class closes. That is, when you're working up a patient for heart failure, what we need to do, we're going to do our echo, right? So your echo is going to tell you ejection fraction. Good. So echocardiogram is probably one of the, if not the mainstay in heart failure, usually. But let me say you wanted to diagnose left-sided heart failure for sure. What investigation are you going to do? If you want to say yes, this patient likely has left-sided heart failure. What is your investigation? right? So investigation would be a right heart catheterization. You measure your pulmonary capillary wedge pressure. One that's more than 18 millimeters of mercury, you say yes, this patient has left-sided heart failure. So the concept behind that is the same things we were talking about, right? The most common cause of right-sided heart failure is left-sided heart failure. But why is that? Because in a left-sided heart failure, when this is your left atrium here, left ventricle, when that pressure backs up into the pulmonary veins, it increases. So you have increased pulmonary capillary wedge pressure in a left-sided heart failure, right? So what you do is a right heart catheterization. Right heart catheterization, what you're going to do is you're going to start in the internal jugular vein. That now is just going to come straight into your SVC. The catheter is going to come straight into your SVC, into your right atrium, into your right ventricle, and eventually is going to go to your pulmonary system. And what you're going to have is increased pulmonary capillary wedge pressure. Increased pulmonary capillary wedge pressure because of the blood backing up. In terms of left-sided heart failure, the blood can't pump out, so it backed up and increases your pulmonary capillary wedge pressure. So to say for sure, this is left-sided heart failure, you'll do a right heart catheterization. That's a distinction question. Okay, good. Any other questions, guys? Great. So now we're going to just answer our question and finish class. So number 10, this is a 60-year-old hypertensive female presenting with gradually worsening fatigue, cough, dyspnea, and orthopnea. On exam, she has bibasal crackles at the lung bases. That's pulmonary edema, everything so far. She's very fatigued because, of course, she can't pump out the blood to get the oxygen to the body. And mild pitting edema. So she has congestive heart failure, kind of mixed picture. So she's fluid overloaded. We admit her to hospital and we fluid restrict her. And we give her diuresis to help her pee out the fluid that she's retaining. And we're doing input-output charting and daily weights to make sure that our fluid restriction and our diuresis is working. We do our echo and we see dilated cardiomyopathy with systolic dysfunction. So that means this patient has HFrEF. Without reading, we can now say this patient has HFrEF. But when we check the patient's ejection fraction, it is indeed less than 40%. It is 28%, so this is HFrEF. No other evidence of heart disease otherwise. Which of the following is least likely to prolong this patient's survival? Well, what is most likely to prolong her survival would be our ACE, ARB, so that's enalapril, that's our ACE inhibitor. Our ARNI, that is sacubitril valsartan. Our beta blocker, that is metoprolol. Our SGLT2 inhibitor, that is dapagliflozin. And the other one would have been spironolactone. What is least likely to prolong her survival is a digoxin. So, everyone, thank you so much. That was heart failure, coronary artery disease, valvular heart disease. I cannot think of anything outside of what we went through that MBBS has tested on or will test on. If I do, I will let you know as the course goes along. Are there any questions on the topics? Are we clear on everything? Does anyone need me to go over any concept, anything at all? We clear, right? Yeah? Great. I have taken up 3.5 hours of your time. Good thing is, Thursday, arrhythmias and AFib is going to be brief. Infective endocarditis is going to be brief. Pericardial diseases is going to be very brief. So the good thing is Thursday is likely to be a short class. I will teach a little bit about the cardiovascular drugs, but I don't want to get you all too myopic and thinking that the drugs that I teach are the only ones they test on. But in the meantime, I want you all to know about antiplatelets, everything about them, the different ones, the ADP receptor antagonists, the aspirin, clopidogrel, blah, blah, blah. Want you all to know about anticoagulants. That is mainly heparin, that is low molecular, unfractionated and fractionated heparin, right? Heparin, warfarin, and your DOACs, direct oral anticoagulants, factor 10 and factor 2 inhibitors. That is apixaban, rivaroxaban, dabigatran, and atrigoban. And I want you all to know about thrombolytics as well. Okay, you need to know everything about warfarin. Okay, guys, so everything about warfarin, the INRs, warfarin reversal in terms of prothrombin complex concentrate, vitamin K, FFP, yada yada. Everything about warfarin is important. Everything about antiplatelets, anticoagulants is important. I want you all to know about the antihypertensives. For the antihypertensives, what I want you all to know would be, of course, the classes of them, the mechanism of action of them, the side effects like something coming, something causing dry cough, yada yada. Mechanism of action, side effects, and use of antihypertensives in diabetes mellitus. Thank you, Dr. Victoria Ramnarine. Right? And I want you all to know about the antihyperglycemics because I don't touch on these things anywhere else. So I want you all to know about all of the classes and how to treat diabetes based on your step-up management. Okay? And things like concepts to note will be sulfonylureas causing hypoglycemia, right? The SGLT2 inhibitors causing UTIs, these kinds of things. Now, as we go along, when we teach on Thursday, I won't be able to go through everything about every drug, right? But just go through the drugs because the two things in terms of when they want you to treat would be hypertension management. So you need to know your GNC guidelines, right? So your hypertension management, and your diabetes management. Okay, when to add drugs, when to switch drugs, etc. I will go through a little bit about the high yield things, but you all need to do that on your own as well. To really get it, to really gather it, and try and practice questions on it because each question is different, and that's where you have to apply your clinical skills to treat a patient, and that's the questions that trouble students. So learn the drugs, learn the guidelines. We'll go through the most high ones on Thursday, right? And that might probably be the longest part of that teaching. But arrhythmias and infective endocarditis, pericarditis is literally very short teachings. So this was most of it here. I thank you all for participating and being attentive. I would really appreciate some feedback, right? I'm sorry for the mic issues. I'll work on that, but appreciate feedback on how you thought the class was. I know it was long. Yes, forgive me for it being long, but other than that, the teaching, the pace, if you're like me doing the drawings, what I could change and improve, right? So just message me directly. Give me some feedback if you enjoyed it. That'll be fantastic to know. It'll motivate me. If there are things to improve on, that'll also be fantastic to know. It'll also motivate me to do better next time. So thank you so much. This was our first class of 3 months. I will get to know each and every one of you as we go along. This was a long class. Go and sleep. Get some rest. I will see you all on Thursday at 6 p.m. That class will finish by 8 to 8:30. Okay? All right, guys. Thanks a lot. See you all Thursday. Please, God.